Hopefully this session will be as interesting and engaging as the first few have been. I'll be your speaker today. My name is Adam Layton. I am an assistant professor of emergency medicine and anesthesiology and critical care medicine at the Johns Hopkins University School of Medicine. I know some of you well and some of you less well, and haven't had the opportunity to meet many of you yet. Um, but I've been working with Dr. Mumbo and Dr. Desalegn and Dr. Tariku and a group of intensivists and emergency doctors in Ethiopia for about 10 years now on a variety of different research projects around capacity building and quality improvement in the space of emergency medicine and critical care. Um, so I'm very excited to speak with you today about a topic uh, that I think is really important to all of our practice, and is really important as we think of how we're doing the best possible job that we can to serve our patients. And that is post-intensive care syndrome. So I'm going to go ahead and get started. Please, if you have questions or comments, feel free to put things in the chat, and we'll have plenty of time to discuss at the end of the presentation. Um, let's see. So just to get off out of the way, I don't have any financial or other conflicts to disclose. Um, the learning objectives for today are really to help you guys to be able to explain the definition and clinical significance of PICS or post-intensive care syndrome, identify patients who are at risk, describe potential interventions to prevent and treat PICS, and then to suggest areas of future research to advance our understanding. I do want to make a couple of big disclaimers as we get started. This is still a very new concept in the medical literature. We'll talk about this more, but this is a term that's really only been around for less than 15 years and is an ongoing topic of a lot of research. So I'm sure that if I give you guys this talk again in a year or two, some of the findings will be different and some of the conclusions will be different. But I think this will hopefully give you a good sense of where we are up until now. And there is a lot of ongoing research on the topic. There's very little data from low and middle income countries or sub-Saharan Africa in particular. This would be a fantastic topic for any of you guys who are looking for research projects to investigate in the African context. Please reach out to me if you'd be interested in doing research around PICS in your settings. I'd be happy to partner with you on that. And then, like I said, we're still early in the course of understanding this process. So there's some promising ideas about preventing and treating PICS, but there are a lot of challenges, especially around implementation and sustainability. And this is still evolving. So as we get started, let's talk about a case. And we'll hopefully use this to frame our discussion a little bit. This is a 65-year-old man with a history of hypertension, diabetes, and depression who comes to the emergency department with abdominal pain. He's febrile, tachycardic, hypotensive. He's found to have perforated sigmoid diverticulitis. And he's taken to the emergency room, or from the emergency room to the operating room for an emergency washout and bowel resection. Post-operatively, he's now admitted to your ICU. He has septic shock. He's intubated. He has moderate ARDS and oliguric acute kidney injury. Sounds like the sort of patient that I think many of us take care of on a fairly regular basis. So first question that I want to ask you guys, and should see a poll pop up on your screen that you can answer anonymously. What do you think his chances are of surviving his hospitalization? So go ahead and take oh, we can do all three of these at once. Amanda, these all popped up at once, it looks like. So three questions.
Sorry.
What are his chances of surviving the hospitalization? If he does survive, what are his chances of still being alive in a year? And what do you think his chances are of living home independently without disabilities a year from now? So again, take a minute and vote if you're seeing these on your screen. This is anonymous. Nobody's gonna share your share share your responses here. But at the end, we'll come back to these questions and see if uh where we think we are. I see 5 responses so far.
Yeah, 6. And Chris just said, can you please post the case again in the chat?
Oh, sure. Here, I was going to go back. 65-year-old man who came in with abdominal pain. He had perforated sigmoid diverticulitis. He had an emergency washout and bowel resection. And what you know now is septic shock, moderate ARDS, oliguric AKI. All right, I'm going to go ahead and stop the poll. If you guys feel free to play it at home in your own heads. The results that I'm seeing, in terms of his chance of surviving, somewhere between 25 and 80%, with more people voting for 80% survival than anything else. His chances of surviving in 12 months, somewhere between 25 and 80%. Um, and most people are saying about a 50% chance of living at home independently in 12 months if he survives. Um, and thanks all for playing along and sharing with us. We'll have a couple other polls as we go along. In terms of, my guesses for these questions for where we are right now, I didn't really give you enough information to answer um, the first question, but we have ways of answering that. And usually we use an illness severity score, something like an Apache 2 or a SOFA score. So we have ways of being more quantitative about that have very high sensitivity and specificity, have good predictive value. In terms of his chances of being alive in 12 months, we'll talk about that. That's really uh, uh, something that we have some data for. And then, what are his chances of living home independently? We'll get to all of this. So what is PICS? PICS, or post-intensive care syndrome, describes new or worsening problems in physical, cognitive, or mental health status that arise after a critical illness and persist beyond the acute care hospitalization. This term can be applied to both survivors of critical illness and also to their family members. And it's important to stress that this is not a medical diagnosis, but it's a concept that's really important for raising awareness and education, for understanding and addressing barriers to practice, and for identifying research gaps and resources. The term really came out of a conference held by the Society for Critical Care Medicine in 2010, with the aim of improving long-term outcomes after critical illness. This was a stakeholder meeting of about 30 people from mostly the United States. I think there were a couple Brits and a couple Australians, but really with no LMIC representation. We'll come back to that a bit. But members of different ICU professional organizations and groups. And this is the framework that they came up with. And so you'll see there's PICS as it applies to the survivor, and that's mostly what we'll be talking about today. It includes mental health disorders, including anxiety, acute stress disorder, PTSD, and depression. There are cognitive impairments, including executive function, memory loss, difficulty with attention, and dementia, visual spatial processing, and mental processing speed overall. And then physical impairments, and this includes things like chronic lung impairment, pulmonary fibrosis, chronic dyspnea, neuromuscular weakness, general increase in frailty, and decrease in functional status. And then in terms of family members of a patient who survives, they can also suffer from anxiety, PTSD, depression, and complicated grief. Um, and so we'll be talking about this more, but think about this as an overlapping framework of mental, cognitive, and physical deficits the patients can develop or that can persist after a critical illness. There was a follow-up conference a couple years later that really talked about, now that we have this concept of PICS, what should we be doing in terms of therapy for these patients? And they came up with some priorities that we'll be addressing, including how do we recognize, prevent, and treat PICS? How do we support survivors and their families better after a critical illness? And what are barriers to improving practice? And then in terms of research, how do we figure out who's at risk? How do we test what prevention or treatment interventions are effective? And how do we better understand long-term outcomes for patients and their families? This isn't a purely adult concept. More recently, there was a similar conference on the pediatric side. In a lot of ways, this really mirrors the same adult framework that includes physical, cognitive, and emotional health for children. There's more emphasis on their social health integration back into a classroom or a social environment, and the impact of critical illness on their normal development process. And then a lot of attention to the impact on families, siblings, parents who are coping with a child's critical illness and how that can impact the child's recovery as well. So like I said, there's been a lot of research about this over the last 15 years or so. And I'm just going to touch on a couple of the different studies that have been published, highlighting some similarities, some differences, how people have been framing these questions a little bit differently and arriving at slightly different answers, to try to give you a sense of where we are with this in 2024, hopefully not in 2018. So the first study that I'll talk about was published out of the United Kingdom in 2013. This was looking at social and economic outcomes, and I think that really I would highlight the fact that they looked a lot at employment and financial impact of critical illness here. This was a 12-month follow-up study of survivors of critical illness. They had about 300 patients who had been in an ICU for at least 48 hours. A little over half of these patients were medical patients, and then about a third were trauma and emergency surgical patients. And about 90% were still alive at 1 year, 89%. The median age was 62 years, and 43% had an Apache 2 score over 18. So that's a pretty good cutoff for thinking of severe illness. And we'll compare that to a few other studies. Patients spent a median of 8 days in the ICU and just under a month in the hospital total. And when they looked at baseline, about a third of these patients had mobility problems at baseline, about a sixth with trouble with self-care, about a third with problems with usual activity at home. About half of these patients had pain at baseline, and about a third had anxiety or depression. And so this baseline is really important in saying what deficits are new after a critical illness versus, if somebody comes into the hospital with deficits, we're rarely making those patients better when they go home. But they found that those numbers went up for everybody, or for all domains of quality of life over after a critical illness, both at 6 months and at 12 months. There wasn't a big change between 6 months and 12 months. And these were significant increases between 13% with problems for self-care and up to 30% of problems for usual activities at home. Many of these patients came home with new deficits. In addition to that, of the patients who had been employed prior to illness, about a third of them reported negative impact on ability, and a third had a decrease in their family income because of their critical illness. 22% needed help with activities of daily living. Of those patients, almost 2/3 required more than 20 hours a week of in-home assistance. And most of the time that was provided by family members. So this wasn't just the patient's own loss of income and loss of ability. This was also a big stressor on these patients' families. This graph is actually showing the impact of a patient's critical illness on their family caregivers. So about half of those patients, family members, had had a change in employment status, usually either having to cut back their hours or give up a job to care for their loved one who had persistent deficits after their critical illness. This was a study from the US a few years later of about 400 patients, looking at patients specifically who had either respiratory failure or shock, who had survived an ICU admission. They excluded patients who had baseline deficits to try to get a sense of really what deficits were attributable to that critical illness. Again, about median age was about 61 years old. The median Apache score is a little bit higher here. It was 23. And you'll see this was a sick cohort of patients. Many of them were intubated, had severe sepsis. Many of them had delirium. At 12 months, 80% of those patients were still alive, so a little bit lower than the previous slightly healthier cohort. And about half of the patients who survived had impairment at 12 months, including cognitive impairment, depression, disabilities with their ADLs that include things like eating, bathing, dressing. And then about 20% of the patients had two or more different impairments. And so you'll see here, this Venn diagram is showing that there's significant overlap, and many patients don't just have one type of impairment, but have multiple different overlapping impairments, which is really, stressing why we shouldn't think about each of these different issues in a silo, but why it's really important to think of this as an overlapping umbrella term and as a syndrome. They found risk factors including lower education at baseline frailty, need for mechanical ventilation, sepsis, delirium, and coma. And you'll see that this doesn't include things that you might have expected, like an injury severity score or an ICU length of stay. We'll talk about risk factors more. This was another slightly more recent study coming out of the Netherlands, um, also looking at the incidence of PICS for patients who'd had an ICU admission. This was a significantly larger cohort. This was about 2,300 patients who'd been in a Dutch ICU for at least 12 hours. Here you'll see that many more of these patients were elective surgical patients, as opposed to the previous studies that were looking more at medical patients and emergency surgical patients. Similar median age in the early 60s. They reported an Apache 4 score, which correlated to an Apache 2 score of about 18. So more similar to that first UK study. Median ICU length of stay was only 2 days, and hospital length of stay was about 10. And they really dug into comparing the differences between the medical, the elective surgical, and the urgent surgical patients. They found the medical patients tended to be older and had more comorbidities, higher illness severity, and longer ICU time. And the urgent surgical patients were the youngest and healthiest at baseline. 1 year after ICU admission, 87% of the survivors were still alive after they left the hospital. And in all of the categories, many of the patients had persistent deficits. These were the most common in the urgent surgical patients and least deficits in the elective surgical patients. And in particular, they found that there was a significant decrease in both physical and mental health for the urgent surgical patients and the medical patients, whereas the elective surgical patients actually reported improvements in their physical and mental health. So maybe these were patients who had chronic back pain and had spine surgery and had improved motor function after having spine surgery, or patients who had tumors that had their tumors removed and had improved function because they'd had a treated malignancy. But they found that even with that, everybody reported overall decline in cognitive function, or all populations reported a trend towards decreased cognitive function after these critical illnesses. And that almost half of the patients had had work-related problems if they had been employed at baseline. And so many of these patients were not back at work supporting their families and earning an income as they had been prior to their critical illness. You'll see here that fatigue and mental health complaints like anxiety and depression were the most common long-term impairments. And they really emphasized that the physical deficits were the most common, and that usually when there were mental and cognitive deficits, those coexisted with the physical deficits. And so maybe here would be a reason to focus on things like early rehabilitation to prevent some of that physical decline. Other risk factors that they addressed included increased age, sex, the pre-hospital functional status of the patients. They did find that longer ICU length of stay was associated with increased impairments long-term, and also lower educational level again. And so maybe these were patients who had more manual labor or more physically demanding work, and because of that, were having more trouble getting back to work because uh, of the physical demands of their work. That's really a great topic for further investigation. Um, Around the same time, a study came out from Japan. And you'll see here, we've talked about England, US, Japan, and the Netherlands. So all relatively high income, high resource settings. Um, this was a similar sort of a study at looking at patients at 6 months, about 100 patients who'd been intubated in a Japanese ICU for at least 48 hours. This was an older cohort and a higher Apache score. About a third of these patients had ARDS, 41% with sepsis. They spent a median of a week in the ICU and about a month in the hospital. And of their ICU survivors, 25% had died within 6 months after leaving the hospital. And 64% had persistent deficits that contributed to PICS. Again, you'll see there's a lot of overlap, especially between physical and cognitive impairments. The less overlap with the mental health impairments. Again, they found that lower educational level was associated with more deficits after critical illness. And of the patients who worked at baseline, the patients who did not have PICS were able to go back to work. Less patients who had developed deficits were able to return to work. And so again, sort of emphasizing the financial economic impact here. In This was a US study uh, specifically to ARDS patients. Um, this was a higher functioning, a younger population, so median age was closer to 50. Most of these patients were living independently. Half of them were full-time or part-time employed. And this was the highest Apache score of these studies. You'll see that there's a wide distribution. Some of these patients, a third of these patients only had mild ARDS. These were patients who spent a median of 2 weeks in the ICU and about 3 weeks in the hospital. 80% of these patients still had deficits. 70% had clinically important fatigue. And these authors emphasized that fatigue was really the main driving factor. Most patients who had other physical mood or cognitive deficits had that in addition to fatigue, not as with fatigue as sort of a separate element here. And they really emphasized the overall impact of fatigue on patients' long-term recovery after a critical illness. They found that it was more common among women and patients who were unemployed at baseline, and they didn't find an association with illness severity either in terms of an Apache score or the severity of their ARDS, ICU length of stay, uh, comorbidities like diabetes, or specific medications that they had received in the ICU. But they did say, as we had mentioned from the previous Dutch study, that really focusing on fatigue, that things like early exercise, nutrition, hydration, uh, mood management, making sure they were on adequate appropriate medications and sleep hygiene may help to improve long-term outcomes for those patients. Then in addition to fatigue, one other thing that contributes to PICS that wasn't part of that original framework is long-term pain in patients who've survived a critical illness. Um, so this was another study looking at long-term outcomes of critical illness survivors, about 300 patients in the United States. Median age was about 60, Apache score in the low 20s again. Again, this was a sick cohort. Most of these patients required mechanical ventilation. About 2/3 had sepsis and 3/4 had delirium. And you'll see that uh, almost 3/4 of these patients still had pain associated with their illness a year later. And for 2/3 of those patients, they said that their ongoing pain affected their quality of life. And so again, being thoughtful about what we can do to set these patients up for better rehabilitation so that they're not having this long-term pain and disability after their illness. I mentioned children before. I'll mention again briefly. Um, this is really a topic that has not been sufficiently researched yet. But there's one study that I could find that was just published a couple years ago, looking at about 200 children who'd been admitted to a pediatric ICU. And they were looking at not at long-term follow-ups, but just at functional status on discharge compared to prior to admission. And they found that even then, about 20% of children had new or worsening physical or cognitive disabilities. They didn't get into mood or impact on family or social integration, but did see some hint that this is an underrecognized and understudied problem in children as well. And they found that maybe having a longer ICU length of stay and more interventions during the ICU stay was associated with increased risk of pediatric PICS. As I mentioned, all those studies that I've been showing you up till now have been from high-income countries and high-resource settings. I was able to find one study out of South Africa. If folks know of other sub-Saharan African research about PICS, I'd love to discuss it with you. And really, I would love to help you guys to generate some of the data to advance our understanding in lower resource settings. But this was a study, was a scoping review looking at different elements of PICS in public health hospitals in South Africa. And they stressed a couple of important differences of really why it's important to do context-specific research. They noted the ICU population in low and middle income countries is younger. There are more trauma and surgical patients. As we discussed earlier, there's good reason to think that patients who have emergency and urgent surgery are more likely to develop long-term debilities. There's more HIV, which may contribute to neurocognitive impairment. Many of these patients have lower socioeconomic status and educational levels than higher income countries, which has been a risk factor for PICS. and then less rehabilitation and mental health services available for these patients. And so they were looking to see what's out there in the South African literature. They found a total of five studies that were addressing different elements of PICS. They found that there was, in the three studies addressing physical impairment, uh, was evidence of persistent impairment, especially in patients who had greater illness severity or longer times on a mechanical ventilator. There were two studies about health-related quality of life, and found the patients often had persistent mental and physical decrements. Again, often more common in patients with longer ventilator times, higher illness severity, and long increased age. And one study about mental health in ICU survivors that found that about half of patients had long-term anxiety, about a quarter had depression, and about a third had PTSD in critical illness survivors. And they found that use of physical restraints in the ICU was associated with increased mental health consequences. So we've talked, from several of these different studies have highlighted different risk factors. Um, this was a systematic review and meta-analysis, including about 90 different papers that included at least one of the different categories of PICS. Um, and they were able to come up with risk factors for each category of PICS. So for mental health, they found that female sex, previous mental illness, and negative ICU experiences, and that sort of aligns with use of physical restraints and more interventions in the pediatric population. So all those were associated with mental health consequences. Delirium in the ICU is associated with cognitive impairment. I think there's an important question there about if that delirium is causing the cognitive impairment, or if patients who have some underlying vulnerability are more likely to develop delirium, then also more likely to have long-term consequences of their critical illness. And then physical impairment, more common in older patients, female patients, patients with higher disease severity. So I think, over the last 15 years, we've gotten a lot of signal about who we should be the most concerned about, who's at the highest risk. The patient that we started off discussing has a history of depression, so that may put him at increased risk for mental health consequences. He had just arrived in the ICU, so we don't know if he's going to go on to develop delirium or have agitation, require restraints that could be a negative ICU experience. He does have ARDS, acute kidney injury, and septic shock, so he's at a higher risk in terms of disease severity. So there's risk. So with all of that, I have another poll question for you guys. Are we able to predict PICS when we have somebody admitted to our ICU, like that patient that we started off with? I'm going to give 3 more seconds for folks to vote. All right. So let's see. I see about half of you think that yes, we are able to predict. 13% said no, and 30% said maybe. So I think that's very fair. There was let's see, a study that was done. Somebody just came off of mute and there's an echo, so please make sure that you're still on mute. There was a study, it was about 160 ICU survivors who they were asked to report what was their quality of life prior to 1 month prior to their illness. And then again, they were surveyed, what's your quality of life 6 months after your illness? And then also at the time of enrollment, so within the first week of the ICU stay, the ICU physicians and nurses taking care of the patient were asked, what do you think this patient's quality of life is going to be like in 6 months? And so interestingly, they found about a third of patients said their quality of life was better, about a third said it was the same, and about a third said it was worse 6 months after their critical illness than they had been prior to it. The patients who said they had a worse quality of life said that it was most commonly associated with cognitive impairment, inability to go back to past times that gave them pleasure, or patients who were in nursing facilities hadn't been able to return back to their home after a critical illness. In terms of things that predicted worsening quality of life, there were some hints of patients who had dialysis, patients who underwent neuromuscular blockade or paralytics, people who required more pain medicines were more likely to have worse quality of life after a critical illness. But when they asked the doctors and the nurses, their predictions were really pretty terrible. Really no better than flipping a coin of, are these patients going to have good long-term outcomes? So I think some of that is why we have knowledge deficits, why we have ongoing research to address these knowledge deficits. But I think it's also important to acknowledge that um, at this time, we're still not very good at looking at a patient and saying this patient is going to be, happy or unhappy with their quality of life long term after an injury. In terms of preventing PICS, we'll pause one more time for a poll. Do you think that we have good interventions to prevent these long-term outcomes? So take a second and vote. All right. So about half of you are saying yes, 40% saying maybe. And I love the optimism. Only 5% of you are saying no, we aren't able to prevent PICS. Um, so let's talk about that a little bit. Um, the really the main approach that we've been using, and this also comes out of the Society for Critical Care Medicine, um, to improve the long-term outcomes of critically ill patients is the ICU Liberation Bundle, or sometimes called the ABCDEF bundle. Um, the goal is to reduce delirium, prevent and manage pain, achieve early mobilization, and really to reduce those long-term consequences for ICU patients. The bundle includes assessing, preventing, and managing pain, spontaneous awakening and spontaneous breathing trials, so protocoled ways of decreasing sedation and ventilator weaning, being thoughtful about our choices of analgesics and sedation, preventing and managing delirium, early mobilization, and family engagement and empowerment. I'm not entirely sure how that comes to ABCDEF, but that was the acronym they came up with. Um, this has been advocated for and implemented really over the last 10 years or so. This was a study that was asking if implementing the ICU Liberation Bundle improves patient outcomes. They found that implementing this in a structured, organized way does improve compliance with spontaneous awakening and spontaneous breathing trials, decreased reintubation, decreased use of benzodiazepines, decreased delirium, and then slightly shorter ICU and mechanical ventilation duration by about half a day. So it does seem like implementing the ICU Liberation Bundle does improve at least short-term outcomes for critically ill patients. This was another much larger study of about 15,000 patients. Um, and they found that it's not just sort of a binary yes or no does implementing an ICU Liberation Bundle help, but for every element of the bundle that was impacted, there was greater benefit. So if you're only able to implement a third of the interventions, there's some benefit in terms of survival to ICU discharge and survival to hospital discharge and decreased death. And the more of that bundle that you're able to implement, the better that your patients will do. So short term, ICU Liberation Bundle is definitely helpful. Long term, does it prevent PICS? I think that we need more research on this. So this was a secondary analysis of the JPICS study, the Japanese study that we talked about earlier. So this was only 200 patients. These were patients who were had a ventilator time of at least 48 hours in Japanese ICUs. And they were looking at whether better bundle compliance was associated with decreased prevalence of PICS. They found that 17% of the patients died in the hospital, 25% died within 6 months. You remember this was the older median age of about 70 population, where 2/3 of those patients went on to have PICS. And they found that 70% of the hospitals were compliant with the ICU Liberation Bundle, and that bundle compliance was associated with decreased long-term mortality, but it didn't really seem to have an impact on incidence of PICS in either adjusted or unadjusted models. there was a signal that maybe in higher volume centers that there may be some impact of the ICU liberation bundle on the incidence of PICS. Again, this is one small study. I think there's a lot of important ongoing research to come about this, but as of now, we don't really have a magic bullet of how we can prevent PICS. Um, One thing that gets discussed a lot is early mobilization, early rehabilitation. This was, oh, was there a quiz there? Oh yeah, there's a quiz there. I'm sorry, I'm jumping ahead. Does early rehabilitation prevent PICS? So the options here are, does it improve mental function, cognitive function, physical function, or all of the above? I'm getting ahead of myself today. All right, so I am seeing, I'll share with you. Um, Most of you were saying that you think that early rehabilitation improves all aspects of PICS. About 10% of you said only physical impairment. Um, so this was a systematic review from a few years ago looking at relationship between early rehabilitation and PICS. Here's a picture of an intubated ICU patient walking with a walker with assistance of a nurse and a physical therapist there. Um, and so these were their forest plots for physical impairment. There was a significant improvement in long-term outcomes with early rehabilitation. But for cognitive impairment, really no impact on delirium and no impact on health-associated depression symptoms or anxiety symptoms. So unfortunately, at this point, it seems like we're really only seeing the positive impact in terms of physical impairment. For PICS. Last question, can we improve long-term outcomes in patients with PICS if early mobilization and the ICU liberation bundle aren't the answer? Are there other things out there for patients once they've developed PICS that we can do to improve their quality of life, improve their functional status um, if they survive their illness? So we've talked about preventing. Now that we've looked at preventing, can we do things to help? Great. And I'm going to end the poll here. And I'm seeing about 80% of you are saying yes, and 20% of you are saying, oh, sorry, 80% of you are saying yes, 20% of you are saying maybe. Nobody thinks that we should give up hope. I love it. I agree with you. I think there's a lot to be done and a lot of research to help us to figure out what are the most effective and cost-effective ways that we can help these patients. So this is a very busy diagram. Looking at management of PICS and really sort of emphasizing that this is not this is not something that starts and ends in the ICU, and this is not something that we should start addressing 6 months out once somebody has said, I'm having chronic pain and fatigue and depression and cognitive impairment, and I can't go back to work. But this is really a continuum, looking at what we do in the ICU, what we do with patients as they're recovering in the hospital out of the ICU, how do we help them to transition out of the hospital and back to a home environment, and then long-term recovery. There are barriers along the way, including infections, blood clots, things that we can do in the ICU that can help these patients, treating things like immobility and delirium, providing rehabilitation as patients are recovering in the hospital, helping to make sure that caregivers are well supported and well informed, having coordinated care as patients are moving out of the hospital, making sure that they have the equipment that they need to live safely and functionally at home, and connecting patients with specialists in rehabilitation services. And then similarly, long-term, looking at the financial burden and socioeconomic barriers for patients who've survived a critical illness and helping them and their families to keep them safe and healthy at home. There have been a number of different interventions that have been studied across all the different domains of PICS. in the hospital early after discharge, late after discharge. This often is focusing on things like physical rehabilitation, nutrition, ICU diaries have been studied a bit for long-term mental health outcomes for patients. Um, Animal-assisted intervention, so bringing pets into the hospital to raise patients' spirits. Um, Geriatricians helping specifically for elderly patients as they leave out of the ICU to provide sort of age-appropriate therapies, connecting patients with physical therapy, nutritional support, cognitive therapy, um, and other sorts of physical therapy as they leave the hospital, and then long-term rehabilitation, nurse-led outreach programs, support for patients and their families, and care coordination. So a lot of different things have been studied. We don't have the answers yet, really, of what the most important aspects of this are. Um, there have been a couple of leading centers in the US that have really focused on the idea of having ICU recovery clinics, which are comprehensive care centers for ICU survivors, to provide many of those different sorts of services under one roof. Um, so this was an early report on a ICU recovery center that was established at a US hospital. Um, Many of these patients had respiratory failure, sepsis, delirium, spent about a week in an ICU, and they came in for a follow-up visit about a month after they left the hospital. And at 1 month out, they found that many of these patients had cognitive impairment, anxiety, depression, physical weakness, and disabilities. And most of these patients had not been able to return to work. And they found that these patients had a lot of different needs. So on average, patients got 4 different interventions. This included things like adjusting medications, stopping things that were no longer useful, or starting things that had fallen off and were helpful to reestablish now that the patient was at a new baseline, referring them to help them connect with the primary care provider or subspecialists, helping to refer to physical therapy and occupational therapy, help with smoking cessation, and then providing durable medical equipment. Um, and so they found that there was a lot of need for this sort of a ICU recovery clinic. They weren't able to show that visits to those clinics improved long-term outcomes, but I think there's a lot of hope that that sort of a structured, coordinated care may help these patients to have a better quality of life and less impairment long-term after their illnesses. And one thing that they found that was that um, this is a topic that's really gaining a lot of interest and traction within the ICU community. It's still something that the general public and that even primary care providers and other physicians really are unaware of. And so understanding that this is something that they need to be vigilant for and that there are interventions that we can offer to help these patients is really important. And so part of this is changing what we do in the ICU, and a lot of this is educating our colleagues so that they can help to provide better care for our patients when they leave the hospital. Um, just one more short commentary about meeting the challenges of critically ill patients in these sorts of uh, uh, follow-up or recovery clinics. They found that there were a lot of common hurdles wherever these sorts of clinics were being established, including space, funding, infrastructure, needing to have a multidisciplinary team that really understood what they were doing and were invested in helping these patients to recover, figuring out who needed to be referred to these clinics and who was most likely to benefit, and then getting buy-in from the rest of the healthcare community, other physicians, administrators, and then the general public. So still a lot of work to be done with this, but a lot of reasons to be optimistic and a lot of promise out there. So back to the patient that we started off with. Um, you'll remember this was somebody who uh, was fairly severe. We didn't talk about what his actual Apache score was to be able to predict his hospital mortality, but I think that those of you who were saying that it was probably at least in the 80% range, that his mortality was at least in the 20% range, and maybe up to 50%. I think we're probably making good estimates. Of course, this has a lot to do also not just with his physical illness severity, but also where he is in the world, what sorts of resources are available to the physicians providing for him. If he survives his illness, what are the chances that he's going to be living home independently a year from now? the number of different studies that we looked at, that's probably in the ballpark of about 80%, maybe 90% um, chance that he's still, so 80 or 90% chance that he's still alive in a year, and maybe a 50% chance that he's independent without significant disabilities in a year. Um, but again, I think it'll be great 5 or 10 years from now when we revisit this conversation and we've developed a well-validated score, like an Apache score can predict your hospital mortality, that we'll have a new score that's able to predict long-term outcomes in critically ill patients. That's not quite there yet. But we do know that our patient outcomes are influenced by the resources that are available and the quality of care that is provided. So the work that you guys do definitely matters and changes the lives of your patients. Our actions in the ICU and during recovery can have significant impact on long-term outcomes. And it's important to be aware that patients may be at risk of developing PICs when we talk about long-term care plans for those patients, when we're counseling patients and their families, what to expect going forward as somebody's recovering from a critical illness, and make sure that they're not expecting that patients will leave the ICU and be home working full-time next week. Finally, in summary, as we've been discussing, PICS or post-intensive care syndrome refers to new or worsening problems in physical, cognitive, and mental health after a critical illness that persists beyond the acute care hospitalization. In addition to the main domains of mental health, physical impairment, and cognitive impairment, pain, fatigue, financial hardship, and social isolation can all be important contributing factors in somebody's long-term quality of life. And then we have identified a number of risk factors, including advanced age, female sex, history of mental illness, illness severity, and delirium in the ICU. But we still don't have great predictive models about who will develop PICs or what their long-term outcomes are going to be. And so there's a need for a lot of ongoing research about prevention and treatment for PICs, and especially research that's context specific for lower resource settings in sub-Saharan Africa. I will stop there and thank everybody for their attention. I'll hand over to Dr. Tariku.